The following is part of Cornell Contemporary China Initiative Lecture Series under the Cornell East Asia program. The arguments and viewpoints of this talk belong solely to the speaker. We hope you enjoy.
So I'm very happy today to introduce to you Professor Karen Eggleston, who comes to us from Stanford. She's the Senior Fellow at the Freeman Spogli Institute for International Studies at Stanford, the Director of the Stanford Asia Health Policy Program, and Deputy Director of the Walter H. Shorenstein Asia Pacific Research Center. She's also a Fellow at the Stanford Center for Innovation and Global Health, and a Faculty Research Fellow of the National Bureau of Economic Research. And the reason that she has so many esteemed administrative and research positions in and around Stanford is because her research is very broad. Pan-Asian, she's lived in China, she's had a Fulbright in South Korea, and so her research is about, she has a PhD in public policy from Harvard, and her research is comparative, about Pan-Asian, about health policy, supply side, economics of health, and all sorts of manner of things, which I'm sure she's going to tell us about today. So please help me welcome Professor Karen.
Thank you very much. Can everybody hear me okay? Great. Welcome, and thank you for that warm welcome to me. I'm really honored to be here and to share with you some thoughts about reform of China's health system. Can anybody read those characters in the title? What did they say and what did they mean? Do you know?
It's difficult to see a doctor in China and it's expensive.
It's difficult to see a doctor in China. It's expensive. Exactly. 看病难, 看病贵. So we'll talk a little bit about that. Does anybody know what is special about this date in the PRC today?
Is the national?
Today is China's National Day, if you didn't know that. So I'm going to talk about health system reforms, the success and the progress in China. And please feel free to ask questions. I know we'll have time at the end, but I can spend more time on some things versus others, depending on your interest. So I'll first go on an overview. As you know, China, with over 1.37 billion, is the most populous country. And its life expectancy has dramatically improved since the founding of the People's Republic, which was when?
October 1st, 1949.
Yes. And so it's grown since then to around 76 years of life expectancy. And health improvements, as you know, will vary greatly across this very large and diverse country by income, geography, and other dimensions that we'll talk about briefly. Since 2002, so early in this century, China has launched dramatic health system reforms, some partly spurred by a SARS crisis and other events, but starting in 2002 with subsidized insurance coverage, so reaching now universal health coverage in China, albeit at a low benefit level, through several different programs, the compulsory, relatively comprehensive employee benefit plan, for urban formal sector workers, and then two voluntary but heavily subsidized programs, the urban resident medical insurance and what started in 2002 with pilots, the Xinlonghe, which is the new cooperative medical scheme in rural areas. So health spending has been growing at rates faster than the growth of the economy as a whole. That means that medical spending is taking up a larger and larger fraction of the economy. It's now around 6%. Anybody know what it is here in the United States?
15%?
3 times that, yes. China doesn't want to get to that large figure, but it's growing very rapidly. As you know, the economy is growing at an unprecedented rate, although it's slowed down considerably, and health spending is growing even faster than that, partly with its universal health coverage. So we're going to talk about what some of that means for people in China. Significant progress, meeting the reasonable expectations, and addressing this problem of 看病难,看病贵, which some will translate as getting healthcare is difficult and expensive, or as recently translated by one of your colleagues. Yet there are many challenges that remain: establishing referral systems from primary care to hospitals, expanding the family doctor system, which is supposed to expand to all of China by 2020, and many others. So I'll talk selectively with you this hour or so, starting with a brief historical overview and then look at expansion of the social health insurance, primary care research, working with the private sector, Healthy China 2030 goals, and so on. So starting with a little history, I worked with some colleagues looking at the dramatic health improvements during Mao era China. When did Mao die?
75.
76, close. Yes, so it was the first half of the PRC. And so we looked at that period as actually the period when the most dramatic health improvements took place in China, despite the Great Leap Famine. We won't get into that, but many of you already know about that. And so there have been a lot of speculation or hypotheses about what drove that dramatic health improvement. The end of war, obviously, political and social stability, better nutrition and sanitation, public health campaigns, childhood vaccinations, primary healthcare infrastructure, which later became the famous barefoot doctors, and gains in educational attainment. So we looked at these determinants of health improvement somewhat systematically, although the data is a little difficult at that time, but we put together a new data set using province-level panel data, digitizing data from all the which are the historical records of public health. And using these techniques, I won't go through the details, but we found that the gains in school enrollment and public health campaigns were very significant in achieving the health improvements in Mao era China, particularly when mothers of infants are themselves better educated and understand the dynamics of sanitation and so on, can lead to large improvements in life expectancy when you reduce the infant mortality rate. So these results underscore the importance of the non-medical, or sometimes because the social determinants of health that we find, and then they can interact with the medical system. So even though I will be talking a lot about medical care per se, don't forget the determinants of your health are overwhelmingly non-medical and have to do a lot of other things about one's life. And those aspects have also obviously been changing in China. One thing, of course, is a dramatic demographic change, which many of you are very well aware of. A decline in fertility, related, of course, to the family planning policies, but also with overall socioeconomic development. As I like to say, the fertility rate is the lowest in one of the cities that never had the one-child policy in China. What city is that? Hong Kong. Yes. And so you can see the median age going up, mortality rate came down, fertility rate went down, and you see the median age increasing. Here I show it in comparative perspective. So you see China goes from around median age of 20 in the 60s and 70s, along with other parts of the developing world, and whoop, goes right up. So it's going to be older than Europe, one of the oldest parts of the world, forecast to be in the future. And as we speak, the median age in China is becoming older than here in the United States. Only other country leading the world, of course, there is Japan. So China's dramatic population aging, remember, at a much lower per capita income, much larger population than the rest of the world. So in effect, the elderly will be about a large fraction of the total population in this country. And there are large disparities in this population and its changes over time. So in some other research with colleagues, we looked at what's called health gradients, which is looking at whether your health and survival differs by your socioeconomic status. And we found, looking particularly at trends in mortality in Shanghai, but also looking nationally where data was available, we find significant differences in health and survival based on, in this case, we use education as a proxy for differences in socioeconomic status. What we have here is a death rate, and I know you can't see the individual lines, but basically from the 90s through 2005 in that reform period, we have death rates, and which ones are these death rates up here? Are these the low or the high educated people? Higher death rate, so this is the lower educated people. This is those with higher education, in which case this would be high school, actually senior high school and above. And median education is around middle school, in the middle here, and those with primary or less education are up here. So you can see the mortality rates were higher, and over that time period, although they're coming down, almost all of them, there's not a lot of closing of that gap. So there are huge disparities that are going on. The data is a little difficult, as you know, because sometimes the migrant population is not well covered, et cetera. I won't go into all of that. But also what was happening over this time period was that China put in place universal health coverage, as I mentioned. So in the tail end of the Mao period, oh, I'm sorry, it's been cut off. But this is the percentage of people with health coverage. And this was in the 70s. And you can see there was a large share from the old cooperative medical scheme. But then these years, which you can't see, through the early 2000s, people in rural areas basically were paying out of their own pocket. That's when you go to a clinic, you take money out of your own pocket and give it to the village doctor. That, of course, was related to the financing structure supporting barefoot doctors dissolving with the household responsibility system being introduced in the rural areas, as I'm sure you have studied. And then it jumps way up again when you get to the reforms in the 2000s. This is data from 2008 because they have systematic surveys every 5 years. And soon thereafter launched a new round of national health reforms in 2009, in April, about a year before Obamacare was announced here. And this was related to several aspects of reform that continued the expansion of social health insurance. Social meaning it's either compulsory like a tax or it's subsidized with taxpayer money. So social health insurance, that's how China has achieved universal health coverage. And the national health reforms focused on 5 different priority areas. One, as I said, was continuing to expand this basic medical insurance. Note that China will often say basic, trying to appropriately manage population expectations that we're not always going to cover the latest cancer drug, but we'll try to cover your basic health insurance needs at a certain percentage of total spending. Then other things that were covered were gradual equalization of basic public health services, such as immunizations, across rural and urban areas and across regions. Strengthening primary care, because China's medical system is largely hospital-based. It's not all that people go to inpatient admissions, but there are large hospital outpatient departments, and a lot of people crowd into there for their higher quality care, reputation for care. They also introduced a national essential drug system, which I'll talk a little bit more about, that had more to do with changing the incentives for doctors than for perhaps guaranteeing access to essential drugs. And finally, reform of government-owned hospitals, which are primary service provider. So now China's health system, it's been restructured at the top several times. Just this spring, the Ministry of Health was rechristened the National Health Commission, and family planning was taken out of the title. The National Health Commission is the primary central agency coordinating all health policies. And there have been a couple of national health meetings by the top leadership and reiterate these directions for reform and goals going forward, including Healthy China 2030, which I'll talk about a little bit more detail, addressing healthcare challenges that systems around the world face, such as how to provide access to the latest technologies without breaking the bank in terms of spending, making it accessible to a broad range of people. Building a Chinese-style basic healthcare system framework, as they say, implementing the universal two-child policy, and interlinking other reforms, maternal and child health, and so on. Any questions so far? We'll get to more later. So this structure maintains what you may or may not know China already had, which is a split between purchaser and provider functions. What do we mean by that? Well, China has social health insurance, so the insurers are the purchasers of services on behalf of patients, and the providers then are the hospitals and the clinics. And this split is manifest because the purchaser functions are through the Ministry of Human Resources and Social Security, which is separate then from the National Health Commission, which is on the provider side. Though obviously there are central and then provincial and local providers. And there are other important ministries that are all involved. National health reform was coordinated under the State Council with 14 different ministries and agencies at the table. But these are some of the most important ones of course, the Ministry of Finance, and NDRC. What does that stand for? Anybody know? Tigaiwei. Anybody know what that is? The National Development and Reform Commission. So those, the former State Planning Commission, those all play important roles in health policy. But there are multiple administrative layers and local variations. So just as an example, there are overlapping jurisdictions. So family planning policies are national, but they're implemented locally. So there are many different variations of the one-child policy or the 1.5-child policy. So if the first child is a girl, you can go on to have a boy in rural areas, and you may know regional variations in that policy and its changes. Each county is a risk pool for the rural health insurance, but can have more or less generous insurance from national guidelines. Each municipality can develop its own national health sector planning and to decide on public-private providers, enforcement of regulations about smoking in public places, and so on. So there's a rich variety of health systems in China. Even though you have universal health coverage, for example, it's not just national health insurance with one big risk pool. China's still a long way away from that. And there are trade-offs if one ever wanted to go to a single-payer system. So China's health service delivery system is composed, as I alluded to earlier, largely from government-owned hospitals. They represent 78.3% of hospital beds as of 2016, latest available data. Private provider share has increased over the reform era when it was made legal again, and has expanded and even been encouraged. National government actually set a goal of getting private sector share up to at least 20%. They didn't actually achieve that goal. The government hospitals still dominate, although the private sector has grown and is now about half and half for-profit and not-for-profit private. Although if you can actually see the numbers in this table, you'll see that the private providers capture a smaller share of inpatient admissions or outpatient visits at hospitals than they do of beds. And that's largely because the large government-owned hospitals still are the highest reputation hospitals and largely crowded and very high occupancy rates there. The private sector accounts for a much larger share, about half of primary care providers. So that's like community health centers, community health stations, village doctors, other township health centers tend to be owned by the government. So what does that look like, change over time? These figures will show you from 2008 on to 2016. The increase in the first column, the tallest column, of course, is what kind of ownership? Public. This encases the number of primary health care facilities, and then you see a growth in for-profit, which didn't exist before, and nonprofit. Although, frankly, if you look in the China statistical yearbooks, you won't see this data. We had to sort of calculate it. They calculated in different categories. So the early years categories might not have been broken out by for-profit. Indeed, private used to be equated with for-profit, and recently they've created private non-for-profit and put in regulations related to that and encouraged it. Here you have outpatient visits, again, public sector continuing to grow and dominating, while the private sector is growing. And here we have inpatient admissions. Any questions about service delivery? So I wanted to get back to the issue of the essential drug list and how it related to the incentives of the healthcare system. Some of you may be aware that there's a long tradition of physician dispensing in Asia related to traditional Chinese medicine and other herbal traditions. This is a quote from a colleague in Japan. Traditionally, physician payment was for drugs. We mean here pharmaceuticals. It was considered morally unacceptable to accept fees for performing a humane service. In this case, the humane service was looking at a sick person and telling them what their medical issue was. So it was diagnosis, was considered just a humane service, and the way the doctor made money was to sell the drug. That is a long tradition in East Asia and some other parts of the world as well. But it can also lead to distortions of providers' incentives. If they're making money from selling drugs, then they have incentive to sell more drugs and sell expensive drugs. And there are other distortions in the incentive structure of China's health system that the reforms have tried to address. So let me talk briefly about it. We know that government hospitals dominate, but unlike many other countries, government hospitals do not receive the majority of their funds from government. As a matter of fact, less than 10% of their revenues come from government. They make most of their money from the patients that get their care at the government providers. So now that's social health insurance that used to be people paying out of pocket. And those prices that they pay are set according to some guidelines. We can get into it, but it's based on a fee for each service, a price for each service. That's called fee-for-service payment. And although there are experiments to moving towards other forms of payment, global budget, bundled forms of payment, we can discuss that later if you're interested. The overwhelming part of the system is still based on fee-for-service, as indeed is this country. So these prices, not market-based prices, but administered prices, were set in a particular way. They were distorted from what a market might reflect, the marginal cost or the average cost, in a specific way. So they were intentionally designed to provide implicit insurance before China got to universal insurance. And what that means is that they priced basic service to be very low. So the patient has to pay out of pocket, but to actually see a doctor and get that humane service, that price was very, very low. As hospital directors like to say, it's much cheaper to stay in a hospital bed overnight than go to a hotel in Beijing or Shanghai. What was priced much higher, remember, the hospitals are making money from their patients, not from the government. So they had to make money on something to cross-subsidize the lower price things. Those things were high-priced diagnostics and pharmaceuticals. So drugs and high-tech diagnostics and procedures were the most profitable things for hospitals, and they had to invest in those and get patients to use them in order to remain financially viable. So not surprisingly, there's evidence of profit-related prescribing. There are two very interesting studies by Curie, Lin, and Zhang and other colleagues, one here in the Journal of Health Economics, later in another journal, that do an experiment. They take fine young people like yourselves, students, and they train them to act like they're a patient with an illness and send them to hospitals to see how the doctors prescribe to them. They find that Chinese physicians, and this was in the flu season, so of course a lot of people were going, and most Chinese often go directly to a hospital outpatient department for cold or flu. They find that Chinese physicians prescribe antibiotics for a start, and all of these patients were reporting things that do not require antibiotics. But over 60% of them were prescribed antibiotics. And some of the patients, randomly assigned, were supposed to say, oh, I understand that taking antibiotics is not necessarily good for you. And they find that those people still received antibiotics 40% of the time. This is just, antibiotics is one signal of the kind of drugs where the physician and the hospital are making that net revenue that they're losing on other basic services, to just reveal the sources of distortion in the system. I'm not picking on doctors. My own father-in-law was a beloved doctor, and he toiled for a very long time. I think it's really the distortion of the incentives in the system that are leading to this kind of behavior. In a follow-on study, which was really clever, they did the same thing with simulated students, so students who pretended they were patients. But this time, they wanted to signal to the doctor that you tell me what's wrong with me, but you're not gonna get any net revenue from that. How did they do that? A clever idea. They told the student to say, my relative owns a pharmacy, so I'm gonna buy the drug there. So they're not buying the drug at that hospital. In that case, prescribing went way down, even more than this other intervention, but they were still prescribing some. So that's just to illustrate some of the distortive incentives. Same thing with high-tech diagnostics in China. Now, the government, of course, is quite aware of this, and many policymakers have tried reforms there, as in here, and other parts of the world. One of the reforms is to bundle payment when you're paying hospitals. And so China has tried this using a system that's used quite often here, diagnosis-related groups, or DRGs. So this was highlighted a few years ago, and there's one study that looks at it in Beijing. So I was going to tell you about the results of that. Unsurprisingly, they have a plausible comparison group, so they can look at changes over time with a comparison group. And what they find is that there was some reduction in expenditures. This is what you would expect. If the provider's not making more revenue from doing higher quantity, this changes the incentive to not do so much quantity, and that's what they find. They don't find cost shifting to number of admissions or ineligible cases, but no data on whether there are changes in quality. So that's still an open question. And of course, the providers had some safety valve that could still charge fee-for-service for some kinds of patients. So I also wanted to talk briefly about some of the impact of achieving universal health coverage. This is a great achievement, of course, that China now has universal health coverage. As I like to tell my colleagues, if you think 40 million uninsured in the US was a problem, try 800 million. That's what China was dealing with. And they have achieved universal health coverage now. You might think that achieving that health insurance, meaning pooling the risk so that not everybody's paying out of pocket, might have implications for health and survival. So we wanted to look at whether there was any evidence of that. Although, even though this has been going on for well over a decade now, some of the later areas are just implementing that a few years, and it might take a while for the results to show up. This was a study that was published in Health Affairs last year. And we were looking at the impact of whether this dramatic decrease in uninsured that took place over the first year of the century made an impact for survival. So the insurance expansions in China were focused in 3 different groups. As I mentioned, here we're looking at the rural areas, the NCMS, and the base for risk pooling there, and the government agency in charge is all at the county level. How many counties are there in China? You know? Well, there are thousands. All right, so there are basically thousands of different insurance systems in rural areas, although they're all under the NCMS rubric. So benefits and premiums vary substantially across all these different counties. The central government sets broad guidelines, as for the other systems, and then there's local implementation. It's financed by individual contributions, then subsidies from the local, so up to the provincial level, and then central. It started with 50 RMB per person per year. If you've been to China, you know you can't buy a lot with 50 RMB per person per year. It's now several hundred, but it's still a small amount. Originally 10 from the household, and then 20 from central and 20 from the other level of government. And importantly, to combat adverse selection, when we get back to if anyone's interested, they required that the whole family join. So you can't just enroll grandma, you have to join as a household. That's one way they combated adverse selection with this voluntary insurance. So we tried to look at the impacts of that. This is what it looks like. So the beginning years in 2004-05 were pilots, and we know those areas were slightly different from the rollout. And then later years, a dramatic expansion towards almost universal already by 2008-09. So there were only a few years there when it was rolling out across all the counties of China. This is coverage based on the data set that we use, which is the same data set that the government uses for health monitoring, such as the infant mortality rate and so on. That's the DSP, if you see in the title there. So we wanted to look at whether this insurance coverage was related to improvements in health. So we know that mortality trends in rural China have been showing mortality rates coming down. So this is a male mortality rate by age group. You can see mortality rate, of course, is higher among older individuals. So that's where we focus. These are middle-aged and younger people. And you can see, you probably can't see very clearly from the back of the room, but basically there's been a large decline. And the most significant one was around the same time period, 6-7, in which NCMS was rolled out. So there's some correlation. But as you know, lots of things are going on in China at any given period of time. And there are many determinants of health. So whether you have access to insurance or not is only one of the things that impacts that. So we thought, well, maybe if people are more likely to go to the hospital when they have a stroke or a heart attack or stay in longer rather than self-discharge because of financial burden, maybe that would have an impact on health. So that's what we looked at, and we used age-standardized death rates, and we looked at the middle and late adopters of NCMS. And we know from a companion study that those early adopters were slightly different, so I won't go into the details there. That's why we looked at the middle and late adopters. And again, I won't go into the details of the estimation methodology, basically a difference in difference based on when the county adopted and so on. And what we find, and by the way, I use this picture because IV drips are very common, particularly in rural China. They may or may not be indicated, right? So although you may very well need an IV drip for some things, if you go in there and get one just for a cold, you're actually at risk of contracting hepatitis and other things. So there are trade-offs to having access to healthcare, just as one example. Better access to healthcare. So what do we find? Well, we find overall that there wasn't any statistically significant difference. Although there is some indication that particularly for rural men, it might have helped reduce mortality from heart disease. But we had very wide confidence intervals. So we think it might take more time to develop. The other thing about helping older people to survive is that you put in NCMS this year. People are not immortal, as you know, and so you may just be postponing mortality and then have higher mortality in later years. So it's a little difficult to tease out the actual effect. But it's important to continue to study because this is one of the largest health insurance expansions the world has ever seen. India's starting to roll something out now. But another aspect of healthcare that might have been different with insurance access is better control of chronic diseases. And we know this is absolutely fundamental for China going forward. Not only is the primary burden of morbidity and of mortality from chronic diseases like stroke and heart disease and cancer and diabetes, but we know that the health spending and the use of services is very high for these diseases among the older population. As we just saw, China's population is aging quite quickly. So a very fundamental task for the health system is to help with control of chronic diseases. So in this study, we looked at whether people, when they had NCMS, were more likely to have their blood pressure under control. And it's some early preliminary data, but we do find that they are more likely to have their blood pressure under control, which is quite important because depending on urban or rural, a large fraction of people may have hypertension or diabetes and be completely unaware of it. So just getting them in there to get diagnosis is one step, and then getting them on some kind of drug. But remember, patients are aware that doctors make money from selling drugs, and so they're not likely to say, oh, I have to take this pill the rest of my life even though I don't have symptoms. They have reasons to be distrustful, and so therefore they might be unlikely to continue taking that medication and keeping their blood pressure or diabetes under control. So some encouraging signs from this empirical research, but we'll have to continue to see whether there are impacts going forward and whether it's related to how China is trying to reform its health service delivery system. Any questions about that so far? Okay, so we know that China started with insurance, and often health reforms will start with insurance. It may seem complicated, and it is, but reform of the health service delivery system is often much more complicated. China itself says it's getting to the high water phase of reform. Remember, in those 5 steps of the initial national health reforms in 2009, the last one listed was reform of government-owned hospitals. I think there's general agreement that was probably the least successful of the 5. We know the first one was very successful. They achieved more than 95% coverage ahead of time, and the other ones more or less so. But reform on the delivery side can be very difficult. It is definitely ongoing, and there are some successful examples. But China's huge, and what works in Shanghai might not work in rural Guizhou, right? So you have to think about all of those differences. So I wanted to share with you a little bit of more recent research with some colleagues about what China is trying to do with primary care. So China's been talking about the next examples of what the barefoot doctors used to do for a long time, that patients need to be able to go to a first contact provider and not have to go to that big urban hospital whenever they have a cold. But patients don't tend to trust their local doctor, and for good reason. The village doctor often doesn't have much of an education, and the primary care providers may not have the most reputable doctors. So it's a chicken and egg of trying to strengthen primary care. But some regions have taken significant steps, and we partnered with the Zhejiang province. Where is Zhejiang? You all know?
Southeast.
Yeah, so near the coast, south of Shanghai. We partnered with Zhejiang province and their Center for Disease Control, looking at some of their health reforms and looking at primary care. This is research joint with two PhD candidates in economics at Stanford and colleagues in China from Zhejiang. So what we did here was assemble a unique data set. For empirical research, you really need data, and China's system is so complicated that it's very difficult to put together information about where patients use care. An individual may have insurance in the local area, but they can literally go to anywhere in China to receive their care if they can pay for it. And the two systems don't talk to each other. So we looked at a particular county and we combined the data sets from different aspects of care, including insurance claims, but also primary care management on the provider side and mortality and surveillance data from the CDC. And we tried to look at when they strengthened primary care management, particularly for patients that had hypertension and diabetes, two key chronic diseases. Was there a benefit of rolling out that reform? And we showed that patients with more intensive management, so that's when the program was really rolling out, those patients did have more primary care visits, fewer specialist visits, fewer hospital admissions, and lower inpatient spending. So it's encouraging that this kind of reform is actually working and beginning to gain the trust of patients and helping to control their total spending by giving them the services they need in primary care and not necessarily in hospitals. So how do we look at that? Well, how many of you have been to a township health center or a community health center in China? Anybody? Not many. Well, if you would like to know, so this is one in Zhejiang province. You can't quite see the machine here that they're using. Zhejiang province, as we mentioned, is eastern coastal China. It's actually one of the richer parts of China, and even the community health centers like this one are reasonably well equipped, although the training and background of physicians is not necessarily the same as for the well-known urban hospitals. And because this is higher living standards and a more robust delivery system, we think of this as maybe an indication of the future of what many other parts of China might be able to achieve. So we looked at primary care management starting in 2009 to more recently. This is funded by that equalization of public health services that we heard about earlier as part of the reforms. So part of that was for vaccination, as I mentioned, and for other public health services, and part of it was earmarked for chronic disease control. So taking that money, 45 RMB per resident of the whole province, 10% for chronic disease control, and allocating that to the community health centers and the village clinics, township health centers. They developed programs to reach out to people in the community, see if they have high blood pressure, hypertension, or diabetes, and invite them to enroll. This is like what the government's trying to roll out nationwide, a family doctor system, where they're inviting the patients in the community to enroll with this local primary care provider. So we looked at some of the impacts of that. This was operated through the local township health centers with incentives offered for management performance. So they would evaluate all of the township health centers and rank them each year and then have a bonus for those that performed well across a range of different services. So we use that information to identify intensive management. We then have all of the demographic information, administrative data, insurance logs, etc., for this period 2011 through 2015 for this county to see what happened. I won't go through the details of the empirical strategy. We measured management intensity in this way with this equation, which looks at the duration of management in that area, accounting for the different demographics in that particular area. And because there might be a problem, the patients that choose management might be different from the patients that do not, or the providers that choose to reach out to more patients might be different from those that do not. So you have a problem of cause and effect. So we used what's called a geographic variation at the boundaries strategy, where we looked at primary care management, which is administered at the township level, but we paired villages, 25 pairs of villages, each within 2 kilometers of each other, but in different townships. And then we could control for the characteristics of those villages. So this is what it looks like. You would have one kind of management here in this township, and another in this township, and then we picked villages right near the border to compare and then use that in our regression analyses. And then controlling for observable differences in baseline health and education of the patients and so on. So, and to use this strategy, you would need to show that actually when you get to a more intensively managed village, you do see a jump in management, and that's what you see in this graph. I won't, again, get into the details, but basically, if you look at villages on this township and villages in that township, you do see a difference, and that's how we're trying to pinpoint causality of the reform. So, and then we run a regression again, controlling for other characteristics of the patients and the providers and the townships where they live. And basically what we find, as previewed a minute ago, is that the higher ranked primary care management, so the more intensive management practice, led to more primary care visits and fewer visits at the hospital or to specialists, and less likely to have to go to the hospital and stay overnight. So reduced avoidable admissions, as they're called, for diabetes and hypertension. And it lowered their inpatient medical spending, and for some patients it lowered their total medical spending. So if their health is the same or better, which we don't have evidence for here, but we do find, and they're spending less, more conveniently, you might think that this is an improvement, both for the patients and for the providers. One way we tried to assess that was with figuring out what was the mechanism in which they achieved this lower spending. We find that mostly to be going back to that issue of trust in taking their medications. Right? We find that the patients that are enrolled in this program in primary care are more likely to consistently take their drugs to control blood pressure or diabetes. And this is one of the reasons why they're less likely to have to rush to the hospital. We also did a small cost-benefit analysis thinking about that per capita spending, remember, from the essential public health services, per resident. That's not per person with high blood pressure, it's per individual in the whole area. And you add all that up, and you find that if you only look at this number of patients, 20,000 or so out of 100,000 more resident population, you look at what they spent less on hospital admissions, the program was already cost effective, not even accounting for better quality of life and other issues that may have applied. Because what we find is that resource savings from avoided hospital admissions were approximately 50 million RMB, and the costs of the program approximately 3 million RMB. So just according to that, it would be highly cost effective. So that's some empirical research about what's been going on with China's healthcare delivery system and trying to deliver better value, more convenience for China's patients and their families. I wanted to also talk briefly about a few other very important topics, such as other aspects of the health industry. Illustrate with biotech. Biotechnology is very big in China, as you may know, and artificial intelligence and its healthcare applications, sort of in reading diagnostic imaging and so on, are very important areas of research in China, which might be a bit separate from poor patients in rural areas accessing basic medical care, but it's also part of what's going on today in China's health system. So an important issue here, of course, is that the government is collaborating with private sector entities in reaching several of its goals. Some is having providers that are not government owned, and some is also in research and development. So, and this is inevitable given many of its goals. Just a few of them are meeting the demand for medical care for high-end services. Remember, they emphasize basic in the government subsidized insurance. They say go ahead and have all those other services available, and even if they're not subsidized, maybe the private sector can help to provide for that, because they're trying to contain government spending growth, as systems all over the world are trying to do. And also, private sector is inevitably going to be involved when China's trying to achieve the healthcare portion of many of its ambitious development plans. So, for example, the plan to make China a global leader in artificial intelligence by 2030 and designating certain firms like Tencent to work on healthcare components and diagnostic imaging and so on. So there are many dimensions of which the government is working with the private sector. I happen to be working on a book with collaborators from Harvard, Donahue and Zeckhauser, on this particular area. I could go into other examples if you're interested. But I just want to highlight that there are many benefits, but also many risks with this kind of collaborative governance to achieve public goals. So some have to do with various aspects of technologies, and I just give a couple examples from specific technology, which is development of vaccines, which are very important technology and have been vital to improvements in health in China and around the world, as you all know. So as one example of public-private collaboration, CanSino, that is named for Canadian Chinese who went back to China and started a firm and developed many innovative technologies, including vaccines, first for Ebola that was approved in China. And this was in collaboration with a military research unit in China. So private sector firm, military research unit, together creating an Ebola vaccine very successfully. So they have many other vaccines that CanSino is working on now, bringing in sort of multinational management expertise with China's domestic market and demands. Yet China has suffered multiple scandals with vaccine. Have people heard about the vaccine scandal this summer? So even when Xi Jinping himself is talking about the vaccine scandal, you know it's pretty big. And so this was, again, an issue with public-private, because Changsheng, this company that had problems with its rabies vaccine and other vaccines, used to be a state-owned enterprise and then was privatized. And there was an article which millions of Chinese read, but then was removed from the internet, about vaccine kings and many other firms that had this characteristic where they were privatized in a non-transparent way, and there were problems with the vaccine, which is just to go back to the issue that the government role is very important for products and services where the individual consumer can't very well judge the safety and quality of that good. And China's still working on revamping its oversight of these kind of industries. And then many officials, of course, have been caught in this scandal, and it's led to statements from the very highest levels. Just to illustrate how the health sector sometimes does lead to being on the top of the policy agenda, just like the SARS crisis back in 2013 may have engendered a lot of the reforms. I'm going to close by talking about the population aging challenges that China faces. We know that as people age, they tend to need help with many aspects of daily life, sometimes called activities of daily living. So just being able to get up and get dressed and feed themselves and bathe themselves. So these are oftentimes called long-term care as opposed to medical care. The two are related but distinct, and countries have addressed these issues in multiple ways. In China, we know there's a growing need, and this is one study you probably can't see, but just to summarize, that they find changes in health of the elderly with a new data set, sample survey of the aging population in urban rural China. And they find, interestingly, that there was an increase in morbidity or ill health among those with minor problems and those among the oldest old with severe problems, but an improvement in between, which is just to say it's complicated in China. Some things are getting better, some things are getting worse. Partly it's related to where you live and who you are, but also, and the changes in the overall population structure. But it also can just be related to the fact that people used to live to 65 and now they're living to 95, and people in their 90s tend to have many more of these conditions, no matter where they live. So they point out to particular issues with elderly being able to bathe themselves and having the support that they need. But there are many challenges with delivering that care. As you all know, China has smaller and smaller families. So you don't have multiple children helping to take care of. You talk about the two grandparents and the parents in the one-child structure, the inverted pyramid. So you have challenges in terms of family members taking care of the elderly. And the elderly themselves are living longer and could be more frail. So China has broadly embraced a three-way division of care to family-based care for the majority, continuing without any financial support from the government, but then also introducing community-based care and only for the most severely disabled, some form of institutional care like a nursing home. So 90%, 7%, 3% for those different categories, rolled out in different ways in different parts of China. They also have tried to introduce some way to help families pay for the care for the elderly. There are 3 countries in the world that have long-term care insurance. Does anybody know what countries those are? Sweden has a great system. It's not long-term care insurance. There are 3 countries. It started with Germany. 2 others are neighbors of China. Anybody know? Japan, definitely, and Korea. Yeah, so, and there are other forms besides long-term care insurance, but those are the 3 countries with national long-term care insurance programs. And China, of course, is debating, do we have the fiscal room to include this? It varies by region. There have been pilots trying to develop long-term care insurance. There are all sorts of issues with that kind of an insurance market. We won't get into the economics of that. But for various reasons, government needs to play a role in organizing that kind of insurance market. And there have been pilots, starting with Qingdao and Shandong and in other areas, some management exclusively by the local government, some joint with commercial insurance companies, some of which are state-owned enterprises or privatized state-owned enterprises or other commercial insurance. There are also national plans to prevent and control chronic diseases. And as I mentioned, the family doctor system, where China is trying to reach coverage by 2020, everybody signing up with a family doctor. That's what this little cartoon is. 家庭医生真方便. Anyway, saying it's wonderful if everybody can have access to family doctor. Family doctors actually go to the home for the disabled and help to care for them. Of course, having just talked with many officials in China over this summer at conferences there, this family doctor system has rolled out quite quickly, but sometimes it's just, on paper. It takes more to really implement it and give it real meaning for the day-to-day lives of the patients and their families. There are many goals. Obviously, I won't go through to increase life expectancy, decrease disability rates. There's a huge issue with smoking among men in China, which continues. A colleague just published a book about that, and so on. There are many, many issues. And there are major goals under the Healthy China policy to try to raise healthy life expectancy and to change the delivery system. So, for example, Goal 5 here, expand the contract service to the whole population. That's 签约医生, which is actually family doctor system. There are many ways of translating these words in English. And realize full coverage. So there are many other goals that are articulated by this and other policies that China is striving to reach to meet the expectations of the population for healthy aging and access to medical care when they need it for themselves and for their families. So that's I have a bit more on integrated care if anyone's interested, or I'll open it up for questions. 谢谢. Thank you very much.